In today's video, we're going over what is the best surgery after an ACL injury. What's going on, guys? My name is Dan Pope, and we also have Kevin Kaufman. We are physical therapists, and we will go through this literature laboriously. Take out all the good stuff, throw out the bad stuff, add our clinical expertise, and deliver it to you, hopefully increasing your brain size a little bit. How's it going today, Kevin?
It's going well. I think that was a good summary of what we've been doing with this research because like we said in our previous podcast episode, there's so much research on the ACL that combing through it all has been fun, challenging, exciting, and definitely ready to learn what the best surgery is for the ACL.
I'm excited too. Let's get this baby rolling. So our lesson goals for today is I want to expose everyone to the different types of surgeries you can get after you've had an ACL injury. And this is going to be with complete tears. So it has to be a grade 3, completely tore the ligament. You'll see some folks that are like 90% torn to get surgery as well. But largely it's a complete tear of the ACL. The biggest one you'll see is going to be the ACL reconstruction. And this is going to be basically creating a graft, usually an autograft. That's from the person. And this could be coming from the patella tendon. This could be coming from the quad tendon. It could be coming from the hamstring tendon. It could also be an allograft, which is going to be a cadaver graft, right? It can come from different parts of the body. We'll talk about that a little bit later. There's also an ACL repair that you can get, much less common. So we'll actually try to suture together the ACL or pin the ACL back down. There's a few different techniques. We'll talk about the new kid on the block, the bridge enhanced ACL repair. So it is a repair surgery, not a reconstruction, although they'll use this bridge, extracellular matrix bridge, to help to repair the ACL. We'll talk about the pros and cons of each surgery. So the return to sport timeframes, return to sport at similar rates of play, as well as we'll go through outcome measures and just see which surgery is potentially best. There's pros and cons of each. We'll talk about best candidates. So if you have a 60-year-old female that is more sedentary, you probably will have a different surgery than let's say a 18-year-old female that wants to get back to soccer, right? And then we'll talk about some patient guidance. So essentially, you want to be able to give your patient good information about their next course of action after an ACL tear. We have direct access in the state of Massachusetts. Oftentimes, we're that first point of contact. Athlete tears their ACL, they go to their physical therapist. They're going to get advice from us. We want to make sure that we do two things. So guide them appropriately, but also have some good recommendations from a physician standpoint, surgeon standpoint, to refer to that doctor so that they can make a really good decision, utilizing the patient's goals, as well as input from the physical therapist and the surgeon, right? What do you think? Is that good stuff, Kevin?
That's pretty comprehensive. I think we'll have a good idea of the best surgical option for patients with ACL after this.
All right, let's get it going. So what is ACL reconstruction? So ACL reconstruction is not a repair, right? And I used to say this wrong all the time. So essentially, they don't go in there and tie the ACL back together. They're reconstructing it. And they're reconstructing that native ACL as best as they possibly can via a graft. And like I said, this can be an autograft from the person's own body or an allograft, which is coming from a cadaver, to make the new ACL, right? And the goal is to replicate that native ACL as much as possible. From a surgical perspective, surgeons are always trying to restore the anatomy as similar as possible to what it was previously, right? And that's actually a pretty big consideration when they're trying to decide on the graft. And the goal is to restore anterior and posterior stability, as well as rotary stability. And this is something I've talked to Lenny about. Lenny's interesting. He's a coworker of mine at Champion, and he treats almost entirely ACLs. I think like schedules like 80 or 85% ACLs right now, which is kind of funny. But he's also worked pretty closely with a lot of knee surgeons. And as I understand it, surgeons are constantly trying to restore rotary stability in the knee, and they will actually do a pivot shift during the surgery to see if they've restored that stability. And if they haven't, they'll may do additional surgery like an LAT. We'll talk that in a minute to try to restore that as much as possible. So that's one of the big things on the surgeon's minds when they are doing this reconstruction, right? So restore that anterior posterior stability as well as a rotary stability. And they want to match the qualities of the native ACL as much as possible. And this does become important from a graft selection standpoint. So you're trying to have a graft that has the same length, the same cross-sectional area, the same level of tissue stiffness, the same tissue makeup, et cetera, et cetera. And every different graft has different qualities. So basically, the physician is trying to match the native ACL as much as possible. And we'll talk about some of these specifics. One study in particular, which we'll note in a minute, they go in painstaking depth in terms of the actual tissue qualities of each graft and basically the decision-making process of why you would choose one graft over another. We're going to have like a superficial glance over that stuff. I felt like it wasn't as relevant for us as physical therapists. If you wanted to read that, you certainly can. I found it pretty interesting. Hey there. Sorry to interrupt, but I've got something cool. It's an evidence-based exercise selection cheat sheet after ACL reconstruction. Sometimes it's a little bit scary working with patients after ACL reconstruction. Obviously, you don't want to hurt them, and the exercises that we choose matter. So I created a cheat sheet to help you out. It goes over which movements have the most strain on the ACL graft and how to dose those exercises from low to high. We use the evidence to guide us so you can make the right decision for your patient after ACL reconstruction. We'll also tackle that age-old question of whether or not you should be using open kinetic chain knee extensions with your patients early on after ACL reconstruction. This cheat sheet is 100% free. I'll leave a link in the show notes in the description below. Go ahead and click on that and get to learning. Now, back to your video. All right, so a couple stats overall about ACL reconstruction in general. So the revision surgery rates are somewhere between 2 and 10%. So revision surgery rates aren't the same as re-tear rates because some folks will re-tear and they don't have surgery, right? So re-tear rates may be higher than that. But in some studies, you may have revision surgery rates as high as 42%, particularly in pivoting sports, right? So you get back to a lot of pivoting, there's a chance that you re-tear. And the amount of re-tear that you get from study to study is going to vary based on the age, activity level, alignment influence, post-operative outcomes, and failure rates. So basically, the reason why the graft choice in the surgery is important is because that is going to influence the re-tear rate, right? And the outcome. So we need to make sure that we're choosing the right surgery, the right graft for the right person. Any thoughts there before we move on, Kevin? I'm just rolling.
Yeah, no, that's good. I think that is an important differentiator to keep in mind because you'll see higher numbers out there for re-tear rates, but as you said, that's not the same as a revision. So, yeah, the revision is when they've had a re-tear and then they go in and get it surgically reconstructed again or repaired that second time. So, yeah, that's just an important differentiator. I think that you hit on.
Okay, ACL reconstruction. What's your favorite graft choice, Kevin, before we move on here?
It's a good question. I'm not sure. I think there are pros and cons to each one. You know, as Lenny being my mentor for this and, you know, learning a lot of what I know about ACLs through him is he's a big fan of the bone patellar tendon bone choice. And I think it does, you know, as you'll talk about some of the pros of it, I think something to keep in mind is I see these folks get a lot of anterior knee pain as we progress in rehab. And, you know, essentially they all develop a patellar tendinopathy is that's what it is. It's a symptomatic patellar tendinopathy for months. And it depends on the person, how quickly that goes away. So unfortunately, there is no one that I just think is amazing. Like they all have pros and cons. And I know you're going to talk about the bear. I think that's where the bear is so attractive and hopefully it pans out well over time because when you don't have to harvest tissue from somebody, they feel so much better. And I see allografts that I actually like treating allografts a lot because they feel great and they do well in PT. It's just that it's not the most stable graft choice. And you'll talk about this stuff, but you know, I'd say I like treating allografts the best. I think it's they feel the best.
Yeah, I kind of agree with you. It's really nice when your patient comes in, you're like, how are things going? They're like, great, I feel awesome, right?
Mm-hmm.
As opposed to like, my knee is really sore today.
Yeah.
All right, so we got a lot of graft choices. From an autograft perspective, you have the hamstring tendon. And this is actually the most common surgery worldwide, which I thought was interesting because I don't see it as frequently, right? I guess it really depends on the surgeon as well, but still the most common worldwide. Then you have Lenny's favorite, the patellar tendon graft. And this is a patellar tendon bone graft. So essentially it takes some bone on either end, and then you have the patellar tendon in the middle. And this is historically considered the gold standard. The newer kid on the block, which we're seeing a lot of recently, is a quadriceps tendon. And what I found was interesting, and one of the reasons why folks like the quadriceps tendon, there's a lot of reasons, but it most closely resembles the size of the native ACL footprint. So they've got good return to sport rates and low failure rates as well, which we'll talk about in a minute. But I also thought it was kind of interesting because it does match what the ACL actually is supposed to look like fairly well. So from a surgical standpoint, it kind of checks off that mark, right? Looks a lot like an ACL. Then you have your allografts, which are cadaver grafts. And I thought this was pretty interesting, but you can have an all soft tissue graft. So you can use a hamstring tendon, tibialis anterior or posterior tendon, peroneal tendon, or an IT band graft, which is kind of cool. You can take the graft from a variety of different places. And you can also have bone tendon grafts. So you can have a bone patellar tendon bone graft from a cadaver. You can have a bone quad graft. So you can take a plug of the bone with the tendon of the quad. And you can also do the same thing at the Achilles. So take a chunk out of the calcaneus and have the Achilles as well. So largely you can take a graft from all different parts of the body. That was something I thought was interesting too, because I initially thought it was just like, all right, you just take a cadaver ACL, and just put it right back in. But it looks like that's not the case. They're using a graft from a cadaver in different parts of the body. So this is a question you had the other day, Kevin. What is the load to failure of different graft choices? So if you take a graft and you pull it from both ends, how much load can it take before it fails? That's probably important because we're trying to have a super strong ACL reconstruction choice. We just want to make sure that we're choosing the best and strongest graft, right? So largely heart et al. Found there's no difference in load to failure in autograft types. I think one of the questions you had was, is the graft as strong as the native ACL? And yes, it is. In a lot of cases, it's much stronger too. But the other thing I found is that there's a large variety of ways to create a graft too. For example, the hamstring tendon, the amount of times they double it over. Also, they'll often add a part of the gracilis to it as well. All these things will influence the failure rates too. So the failure rates in the study, I forget what they were, but it was kind of like a lower number and a super high number, depending on how much they add to that tendon to make it stronger and more robust. For allografts, so essentially if you have a cadaver graft, the preservation and cleaning process is actually very important because it influences failure rates. So if you have increased irradiation to that allograft, it's going to reduce the load to failure. If you have glycerolization, lyophilization, or preservation with chloroform methanol extraction, that reduces the load to failure. So when I was a newer physical therapist out in Colorado, there was a group of physicians that all loved doing cadaver grafts for professional soccer players. And I reached out to them to figure out why. And they said they thought the allograft was a good choice because they're getting athletes back to football, soccer faster, right? And they thought that the re-tear rates, which, spoiler alert, the graft choice, allograft, cadaver grafts fail at a higher rate, was due to this poor preservation or cleaning process. And now that they've come up with better preservation processes, that the failure rates are better. Spoiler alert, that's not the truth, right? But that was what these surgeons were telling me as a reason why they use that, right? Largely, the fresh, frozen way of preserving these grafts is going to be best. And when they utilize that method of preservation, they have similar biomechanical factors as an ACL. So pretty dang strong, good graft choice on paper, right? Any thoughts on that before we move on, Kevin? Kind of interesting that different surgeons like what they like.
Totally. Yeah. I think that's what it gives us a lens into is how are surgeons determining which type of graft to use. And I know Lenny will talk about it depends a lot who they trained under and what the person they trained under liked to do, and how they find that they get the best outcomes with their patients. And I think a funny thing you'll hear is a lot of surgeons. I had a lady who has an allograft, and one of the local surgeons was telling her that, kind of boasting that he has the best grafts. He gets the best graft types, and took a lot of pride in that. So, like you said, whether that bears out in the research or not is a question that we can look at and see if there's a good answer for. But I know that it's something surgeons give a lot of thought into is, where are they getting these graft types, specifically for the cadavers. And some think theirs are better than others, and maybe they are. And we just need more research to show that. But I think that's something you'll talk about. But it's interesting because it's not like you had said, and I've talked to one of our PT students about this, is why don't we just use for cadavers someone else's ACL? But that's not what they do. And it must be because it's not as strong as these other locations that they'll take it from, like the Achilles tendon or the IT band or something like that. That must be a little bit more robust than the native ACL that they take from somebody. So there's a lot of consideration about where to take it from.
Yeah, that's interesting. I don't know the answer to that. Hopefully we could maybe talk to someone at some point to kind of get that answered. But it does bring us back to like this is like a theme, I think, from a lot of our podcast episodes, is that we're always trying to protect our patients, right? Because sometimes you will have surgeons, and I'm not trying to throw surgeons on the bus. There's a lot of great surgeons out there, but some just have these wonky ideas. They just hold on to this thought that like, this is the best thing, even though more research comes out that's like, it's not, but they still believe in that strongly. And I think that's a bit of a problem. And sometimes I find myself steering my patients away from some of those docs for that reason, because it doesn't make sense. I mean, we used to have, out in Colorado, we'd have athletes, cadaver grafts, professional soccer athletes return to sport at 4 months after cadaver graft because they feel good. And that's the main reason why. And these docs felt like the re-tear rates were okay, so they kept doing it. But we know that's probably not a smart move, right? And I had some patients, unfortunately, had multiple re-tears, young athletic patients, and that stinks, right? It stinks to go through that process multiple times when maybe some of that could have been prevented if they got an autograft from the get-go. So unfortunate, but does happen. We're always trying to protect our patients, right? All right, good old ligamentization. So another interesting part about an ACL reconstruction is that when you put in a new graft, it goes through the process of ligamentization, which is a process where the graft takes on new characteristics to match the prior ACL. And this can take anywhere between 6 months and 4 total years. And what is also interesting is that as this process is occurring, the ligament, the graft, gets weaker for a period of time. So when it first goes in, it's quite strong. And then somewhere between around 8 to 10 weeks or so, depends on the graft, as we'll talk in a minute, it actually gets quite a bit weaker. And then it gets stronger and stronger and stronger over the course of the next several months to years, right? And this is a consideration that changes from graft to graft. So essentially, the bone, patellar tendon bone, ligamentizes fully somewhere between 6 and 12 months. The hamstring takes somewhere between 12 and 24 months. The quad tendon generally ligamentizes faster than the hamstring. And the allograft has a slower graft maturation process overall compared to the autograft. And what I will say is that a lot of this evidence is mixed, and the ligamentization process doesn't always correlate with laxity clinically. And that's kind of like, this thing is freaking strong in the beginning, and then towards the middle, not quite as strong. But when it's not quite as strong, doesn't mean that you're going to be unstable necessarily. But this is one of the thought process we go through. We're trying to determine return to sport, right? So an athlete may move extremely well at month 4, month 6, whatever it is, but that graft hasn't gone through this ligamentization process, which is a bit of an issue, with some studies showing it takes up to 4 years for this to occur fully. That's an entire high school sport career. If you have a freshman that tears their ACL, you're like, all right, well, you can play college sports, but not high school sports, right? So there's got to be some sort of happy intermediate, which I'm sure you'll talk about in the next few podcast episodes of when to return athletes back. But just keep in mind, this process takes a while. and is different from graft to graft, and is also a consideration with your individual athletes. I know that we both work closely with Dr. Ramappa, and when he has an allograft patient, he wants to make sure they're waiting longer to return to activity. And this is tough for those folks. So we just talked about, they feel good early on, but we're also telling them to wait for an entire year until they return back to skiing, which patients hate, right? But that's the reason why, because we're trying to use our brain. These patients feel pretty good, but that ligament isn't really healed yet. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door, so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now. Any thoughts on that quickly before we move on, Kevin?
Yeah, I think that's one of the coolest processes that occurs, is that tendon tends to become more like a ligament. And, it's just kind of amazing that the body does that. And it must just be either the forces that it's getting or the blood supply that it's getting. But that process does take time. Like you said, there's a happy medium between when are you physiologically ready versus when does the timeline want you to be ready, and when do you want to be ready? So all that's a big consideration, but it's important to keep that in mind, because there is a point early in rehab where people kind of progress from that early post-op phase and they're feeling better and they want to do more, but they might, that's where you had said perhaps their graft is at the weakest point, and we have to continue to protect them and make sure that they don't do anything crazy in that period. And all of it is a big education process that, hopefully begins pre-op, and then, the surgeons hopefully giving them some of this information, and we're giving them some of this information just to set realistic expectations. So they're not thinking, I feel amazing, why can't I ski with this allograft at 7 months? And this is where we can help educate them that we might want to wait a little bit longer because of the immaturity of the graft.
Good points as always, Kevin. All right. So are there differences between the different types of grafts in patient-reported outcome measures? We're looking at quad tendon versus bone patellar bone versus hamstring And here's the thing. There's no difference in outcomes generally. There's usually lower morbidity in the quadriceps tendon. What the heck does that mean? So just having some sort of complication from the harvesting of the graft, right? So if they're taking the quad tendon, seems like that tends to create less pain right around that incision area or other complications, right? The double bundle hamstring technique improves functionality and complication rates versus a single bundle. So what that means is you take the semitendinosus, the hamstring tendon, combine it with part of the gracilis tendon, so you have two grafts, put them in together, that improves your outcomes as well. So some of the studies I was reading, including this one that we just have pasted right here to the right, if you're watching the video portion of this, if you bundle the two together, better outcomes. So that's one of the reasons why you'll see this from surgeons, because it seems to improve the stability of the joint, right? And then if you look at autografts versus allografts, so from yourself or versus a cadaver, older research reported worse outcomes in the allografts. What's interesting is that newer research is showing no difference, right? And I don't know if that's just because of the way we're now preserving these. Now they're more fresh frozen. Are we getting more benefit from those? I don't really know, but that's one of the things that we're seeing trend-wise from a outcome perspective. All right. And here's the thing that we're all very much concerned with as physical therapists. What are the graft failure rates? We already learned that graft failure is relatively high in ACL reconstruction, and that's a problem. So we want to choose the best graft that reduces failure rates as much as possible. Here's what you'll find. Quad tendon and bone patellar bone has similar failure rates. And this is somewhere between 1.4 to 7.5% in the quad tendon group versus 2.0 to 5.1% in the bone patellar tendon bone. And then there was no difference from a statistical significant standpoint between those two groups, right? However, the hamstring has a slightly higher re-tear rate. So one study had 47,613 patients, so very high powered, and they found the percentage of tears was 2.8 in the bone patellar tendon bone graft versus 2.84 in the hamstring. So that's a very, very small increase, but that was statistically significant because it was such high-powered studies, so 47,000 participants, right? However, in other studies, there's up to a 2 times higher re-tear rate, right? So in some studies, you'll find the hamstring tears 2 times more likely compared to the bone patellar bone graft, right? And this is going to be more pronounced in younger athletic patients. So if you have a younger athletic patient, you probably want to consider the bone patellar tendon bone or the quad tendon over the hamstring. I just thought it was interesting. The hamstring is still the most common procedure. And one of the ways that surgeons will try to bolster the hamstring is through adding the gracilis as well as an LET procedure, which we'll talk about a little bit later, right? That's actually relatively common that we see from time to time. If you look at allografts versus autografts, there are higher rupture and reoperation rates in the allograft, right? And that's one of the problems with using a cadaver graft. And they're up to 6 times more likely to re-tear, particularly in young athletic patients. This is one of the reasons why I wanted to call the surgeons out in Colorado that were liking to use cadaver grafts, because I was reading this research, didn't make a lot of sense to me, right? Again, I think it's one of those instances where I feel like I was right, humble brag here, but you're trying to protect your patients. And one of the reasons I called particular surgeons because I had a patient that tore twice. He had an ACL reconstruction, cadaver tore it. And very interesting. And I couldn't find much research about this, but first time he retore it was hyperextension injury. Second time he retore it, he tore his meniscus. And when they did an MRI, the body just ate the graft. So what's interesting is that in some cases, and you don't really see this much in the research, is that your body, it's not your own body they're putting into you, it's cadaver graft. And your body sometimes dissolves that, eats that, right? So that's another interesting kind of thing that does happen, phenomenon, right? And I do feel later on, his third study had an autograft and he's done fine to this day. It's actually been over a decade. But yeah, that was one of the things that concerned me. And you will see that. You will see some docs still doing the cadaver grafts, but yeah, they have a higher re-tear rate. What's interesting about these is they have substantially lower re-tear rates in older and less athletic patients, right? And this is what we tend to see a lot clinically. If you're over the age of 40 and you want to get back to, let's say, skiing, some of the docs we like, they will prescribe the cadaver graft. And there's no difference between different types of allografts. So if you use the Achilles, the tibialis anterior, posterior, etc., seems like they all have the same graft failure rates, right? And the last thing I did find from another study is that if you use bioabsorbable screws versus metal screws, that reduces failure rates as well. I personally don't know what type of screws the surgeons I work with utilize, right? But I just thought that was interesting and maybe something to look at. Hopefully your docs are using those things. Any thoughts before we move on there, Kevin? I know this is kind of like probably the biggest part of this lesson today.
Yeah. Yeah, I think one of when you were talking about surgeons changing their minds, I think, we're all guilty of that. Every profession is guilty of that, is we get used to doing the same things over and over, and we're resistant to changing a little bit with newer evidence coming out that challenges the way that we've normally done things. So I think in this situation, it's good to recommend to your patient to maybe just get a couple different opinions from different surgeons. Go and meet with a couple and see what they're recommending, and hopefully we can play a role in educating them as well. If they're going with a surgeon like your patient was, who was going to do an allograft in a young active person, we just want to present our case to the patient and let them know, hey, this is what some of the research is saying. Why don't you go get a second opinion from another surgeon and just consider what they say? And then you can use all that information to kind of help make a decision. And it takes some nuance, because you don't want to badmouth surgeons, and you don't want to act like we know everything and they know nothing, because they know a lot of things we don't know. But it's also trying to protect your patient. So it's, introducing it in a friendly way where that patient can maybe get a second opinion from a surgeon that you trust in the area. And, after you educate the patient and give them things to think about, ultimately, at the end of the day, it's still their decision. And if they want to go with the allograft, that's up to them. But it's our job to help educate them and let them know what the potential risks are. So definitely something important to keep in mind.
Yeah, and I don't want to go too in depth into the story just because we got a lot to cover, but it was a mess. So I was concerned the entire time, and it wasn't just the concern that the patient had a cadaver. It's just that the patient was also encouraged to return back to sport around the 4 to 5 month mark, right? Which is super fast. And that was very scary to me. And the other part that was frustrating to both me and the patient's father too, is that I was trying to reach out to the surgeon for a long time, and I really wasn't able to reach the surgeon. And that's another big problem that I think a lot of physical therapists face. So then you have the physical therapist, me, saying, I'll reach out to the surgeon, we'll try to figure this out. And then essentially the patient is getting frustrated because there's a lack of communication. Surgeon's busy. They might not be able to return phone calls. Eventually we did get a chance to chat. We kind of talked through a lot of this stuff. And I already kind of spoke about how that went. But yeah, I just kind of retore a few times. Unfortunately, returned probably too soon with the wrong graft. And my communication probably just, or lack thereof, probably just frustrated the patient, further. So it was a crappy situation, but I mean, the reason why you do want to try to protect your patients as much as possible. So yeah, good times. Yeah. All right. So how about from a strength perspective? Is there a difference between the different types of grafts? In terms of knee extensor strength, the hamstring tends to outperform the bone patellar tendon bone graft, which tends to outperform the quad tendon. And this is at the 5 to 8 month mark, and it may normalize somewhere between 9 and 15 months. There's a few studies that kind of support this. So essentially long term, most folks do get more symmetry back, right? At least between the graft types. Well, you'll probably talk about this later. It's hard to get that quad strength back over the course of time. But largely the different graft types will normalize after a given period of time. It just takes quite a bit of time. But especially between that 5 and 8 month mark, you may find more weakness in the quad tendon group in particular, followed by the patellar tendon. And lastly, hamstring tends to do the best, right? And then it flips from knee flexor strength. So essentially the hamstring strength is reduced substantially up to 2 years following surgery, whereas the quad tendon is pretty much equal to the bone patellar tendon bone grafts. And this is also a problem. It's tough because the quad is super important, right? We know this, but so is the hamstring. Hamstring strength is super important because it helps to counter the quadriceps pulling the tibia anteriorly and putting strain on the ACL. So it's almost like pick your poison, right? We know that they're both extremely important. We want to ensure that we're doing the best thing for the patient, but at the end of the day, there's pros and cons of both. The one thing that surprised me is that it seems like the knee flexor strength takes a lot longer to return than the quad strength. And I think as physical therapists, we don't see people at the 2-year mark generally. We're seeing people, if we're lucky, up to around 9 months or so, right? And measuring at that point before we send them back to their sports. And the quad has a better chance, based on these studies, of returning compared to the hamstring, at least from a graft standpoint. So pros and cons of both. All right. How about return to sport rates? So essentially, if we choose a specific graft type, it's just going to influence the ability for the patient to get back to sport. So overall, about an 82% return to sport rate for athletes after ACL reconstruction. What's really unfortunate is that only about 63% of these folks are returning to sport at the same level, right? So folks are getting back, but not the same rate. That's not really great. And there's generally no difference between graft types. There is mixed evidence on the quad tendon. Quad tendon is new kid on the block. You see some smaller studies popping out showing better return to sport rates. There's a few that show like 100% return to sport rate after quad tendon, although keep in mind that is mixed. There are similar return to sport rates for allografts also, but just keep in mind the autograft is potentially better from a failure standpoint. So you still want to consider the failure rates and not just say return to sport rates are the same. Go ahead and get that allograft, right? Any thoughts before we move on here, Kevin?
Yeah, just to reiterate what you said on the previous slide about the strength and when it comes back, that's definitely in line with what I see and why I feel like it's a big challenge to work with patellar and quad tendon, just because we put so much emphasis on quad strengthening that these folks tend to get symmetrical hamstring strength really quickly. I think generally in the first 3 to 5 months, but the quad strengthening for them is often delayed with pain. But exactly on the flip side with the hamstring, oftentimes we're still working on the quads a lot because of the knee effusion early on, and they start to get weak in the quad, but they do get that back a little sooner than the other two. But that hamstring strength can lag a lot. And that matters a lot for sprinting sports. And that's definitely something that's an issue, is getting that back. It seems like those folks have less pain in the hamstring than the quad and patellar tendon have in the anterior knee. But getting that strength back takes quite a long time and is something that is a persistent challenge. So they both, or all three of them, have pros and cons, I guess. But yeah, I think what you said was exactly right.
So putting on my clinician hat a little bit here, if you have someone that has anterior knee pain, right, and they have quad weakness, that makes rehab extremely hard.
Mm-hmm.
So I think one of the reasons, and one of the things you'll see now, I think in the social media world, is that physical therapists are like, why do surgeons like the quad tendon so much? They're so hard to deal with, right?
Mm-hmm.
And this is not the case for everybody. Some people have a quad tendon and they move beautifully. They have minimal pain. They look great, right?
Mm-hmm.
Because we'll see a lot that are very stubborn, a lot of anterior knee pain, very weak. And the thing is, we're trying to get people to move well. So being able to descend into deeper degrees of knee flexion, be able to translate that knee forward is such a huge goal from a physical therapy standpoint. These folks just have a lot of trouble doing that. So pain, weakness, it just seems to delay physical therapy, rehab so much. And I think it ends up being a situation where the surgeons are like, these guys are doing great. You know, look at these return to sport rates. Everything is looking really good. And physical therapists are saying like, these things seem to have some major problems, because I think that physical therapy just relies so greatly on folks not having anterior knee pain, not being weak in the quads in particular. So I think that's one of the reasons for the discrepancies. Obviously, the stats show the quad tendon does well, but I think from a physical therapy standpoint, it's just a little harder for us. You know, I'm not sure if you notice the same thing, Kevin, but
yeah, the other thing I'll say quick is just the strength is one thing, but then the movement quality is a whole nother thing. And I think it really takes an expert clinician and coach to try to train them to load their knee, because they're going to choose, this goes hand in hand with gaining strength, but they're going to choose a movement strategy that unloads their knee. So they're going to choose a hip dominant strategy, and they're going to start doing a bunch of different things to try to create force without loading the knee joint. So we have to find ways to reduce their knee pain with loading and get them to load in a good way where they're getting their knee involved so they can get stronger, and that will help their knee pain long term. But the longer that you let them feed into these compensations, it becomes so difficult 6-7 months out to change someone's movement strategy that they've really hammered home those first few months as they're avoiding pain. So there's a lot that goes into it, and you really have to pay attention to those things.
Yeah, for sure. And I might be misremembering, but generally speaking, I want to say the quad tendon is worse than the bone patellar tendon bone, but the rate of force development is also worse in these folks. And I think that becomes really problematic when you're trying to jump with somebody. So doing something like a single-legged squat when a weak, painful knee is tough, but then try jumping and landing with that thing, right? So it delays that whole rehab process. Now all of a sudden I'm like, I don't know if we should be jumping, and we're at the 4-month mark, then we're at the 5-month mark, or the 6-month mark, and they're approaching that 9-month return to sport period, and we're like, things still don't look good, right? I think in our minds, we just start thinking like, this quad tendon, I don't know if I like this as much. I know Lenny just had, I don't know, he gets all fired up about these things too, but he sees a lot of ACLs. One of our coworkers, I've mentioned a few times now, but he sees a lot of ACLs, a lot of quad tendons getting more and more popular. And one of those trends is like, man, they just don't look great from like a rehab standpoint. But long-term research is showing they're good. So I'm not trying to hate on them too much, but I think that's the reason why we think they don't do as well. It's because they don't seem like they do as well from a rehab perspective. All right, let's talk a little about donor site morbidity and complications. So essentially the donor site means you have to harvest a graft from, let's say, the hamstring or the quad tendon or the patella. You can have pain as a result of harvesting that, right? We just talked a little bit about that. If you take the quad tendon, it tends to create some anterior knee pain. Same thing goes with the patellar tendon. And generally speaking, bone, patellar tendon, bone has more anterior knee pain as well as kneeling pain compared to the hamstring graft and the quad tendon graft. So the bone, patellar tendon, bone had more anterior knee pain than the quad tendon pain. Or quad tendon graft. So I just made this big stink about the quad tendon being problematic. You have the same thing that goes for the patellar tendon. And if you look at the percentages of folks that have anterior knee pain, the bone patellar bone graft, 72% of these folks end up with anterior knee pain versus 44% in the hamstring graft group versus about 9% in the quad tendon graft group. So, I just made this stink about anterior knee pain. The quad tendon in these studies actually had the least amount of pain in the front, right? The other thing I did find is that if you use a quad tendon soft tissue graft, ends up with significantly more anterior knee pain than if you take a bone plug so basically if you use a quad tendon patellar bone graft. So if you take a chunk of that bone, you're 2.7 times more likely or less likely, to have anterior knee pain than if you just use a soft tissue graft, right? Hopefully that made sense. Essentially, the soft tissue graft is more knee pain than if you take the bone plug with it, right? The hamstring tendon graft has a higher risk of infection. So it's 5 to 8 times more likely to create an infection than the bone patellar tendon bone. And the quad tendon actually has even less risk. So you can see based on all these stats, that quad tendon is looking pretty good, pretty juicy right now for a surgeon. The allograft has a higher risk of infection versus the autograft, so even worse than the hamstring. And the allograft has no donor site morbidity. You already alluded to this. So essentially, these folks tend to feel a lot better after surgery just because they didn't have their hamstring harvested, their quad tendon harvested, their patellar tendon harvested, right? They tend to feel quite a bit better. And you just got to keep in mind, those folks actually ligamentization process, whatever the word is, a little bit more slowly, despite feeling better, right? So that's a little bit of a problem there. Hey, friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up, it's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for a 1-week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside. Any thoughts before we move on? Because we're about to kind of shotgun between some of the pros and cons of these graft types.
Yeah, like you said, I think on paper, the quad tendon looks pretty good with some of those statistics. It's interesting. I would have thought it would have had more higher rates of anterior knee pain, especially pain with kneeling. But I guess it's a little bit superior to where the stress would be on your knee with kneeling. And then I definitely would want to know why hamstrings have such a higher rate of infection. That's interesting. Whether it's like the back of your knee gets a little more sweaty or something. But
I don't know. I didn't look into that, but that is interesting.
That's a huge, I mean, that's a big rate compared to the other one. So
yeah.
Pros and
I
cons.
wonder what the initial risk percentage is. And then like, obviously it was like 6 to 8 times, whatever it was. That's quite a bit more, you know. I wonder if it's like still an issue from like a absolute risk perspective. The relative risk is high, but the absolute risk may be like minuscule. I don't really know, but
good point.
Just kind of like you had said, you know.
Yeah.
All right. So let me make this big so we can kind of see this a little bit better. So we're going to go through the different graft types. We'll talk about the optimal patient, and we'll talk about the advantages, the pros, and disadvantages, the cons. So first graft type we're going to talk about is the quad tendon. And who is the optimal patient? Usually it's someone who is younger than 35 years old. They want to get back to a higher level pivoting sport and or high physical demand, like work or an activity or sport that requires kneeling. These are going to be optimal in skeletally immature patients as well. Some of the advantages of the quad tendon: they have comparable graft rupture rates of the bone, patellar tendon bone, which is the gold standard, lowest rupture rates. They have a lower donor site morbidity than bone patellar bone, but comparable to the hamstring tendon. There's a possibility of a single site bone block harvest. So if you need it, you can take some bone with it. There's a possibility of individualized graft size by harvesting partial or full thickness graft. So one of the things you're trying to do is to mimic the same size in the cross-sectional area of the native ACL, and you can have some variability in the way you do the surgery to match that a bit if need be. And you have less flexion strength loss compared to hamstring tendons. Some disadvantages are that there's no longer-term outcomes quite yet. So essentially, we don't know how well they do 10, 20, 30 years down the line, just because it hasn't been studied as much yet. There's going to be decreased extensor strength, particularly in the short term, and that's compared to the bone, patellar tendon bone, as well as the hamstring. There's also a risk of patellar fracture or quadriceps tendon rupture. It's very low risk of quadriceps tendon rupture and fracture, but obviously when this does happen, this is a very bad thing to occur. Let's move on to the bone, patellar tendon bone graft. The optimal patient is going to be less than 35 years old. The optimal patient is going to be participating in higher level pivoting sports or high physical demand. Some advantages is that you have bone to bone healing. So essentially you have bone on both sides of the graft, which potentially heals a little bit better. So you can potentially perform more aggressive rehabilitation just because that bone may potentially be healing faster early on. There are low graft rupture rates comparable to quadriceps tendon. They have high return to sport rates. The disadvantages are the highest rate of donor site morbidity and anterior knee pain. So these folks tend to have more pain in the front side of the knee during rehab. They have higher rates of osteoarthritis progression. There are some studies that show that. We talked a little bit about that in the last episode. They have a risk of patellar fracture or patellar tendon rupture. Very low risk, but there is a risk for that. There's no option for skeletally immature patients, meaning that they have to take some bone, and it might not be appropriate or isn't appropriate for younger skeletally immature patients. There's a possible higher risk of contralateral ACL rupture in some studies and decreased extensor strength. Let's move on to the hamstring tendon graft. The optimal patient is going to be moderate sport and/or activity level. If there's a smaller ACL footprint, the hamstring may match that a little bit better. If they have a desire to return to work or activities or sports require kneeling, just because not harvesting from the patellar tendon area, it takes stress while kneeling. It is appropriate for skeletally immature patients. The advantages are lower donor site morbidity compared to bone, patellar tendon, bone. There's a possibility of individualized graft size by additional gracilis tendon harvest, different graft configurations. So they can optimize the graft via adding on the gracilis or modifying the hamstring tendon itself. There's no risk for patellar fracture or extensor mechanism rupture. These are very low risk side effects, but they can occur, and they're definitely not good when they do occur. And there's lower osteoarthritis progression compared to bone, patellar tendon, bone. The disadvantages are higher graft rupture rates compared to quad tendon and patellar tendon, especially in younger and active patients. That's why it's a little odd that a lot of docs still will do hamstring grafts in younger athletic females, right? There's increased anterior tibial translation after hamstring ACL reconstruction, possibly due to reduction in hamstring force. My apologies for messing up there. I'm just trying to read this straight off here. ATT is anterior tibial translation. So there's a little bit more laxity for these folks compared to the bone, patellar tendon, bone. There's a tendency towards higher surgical site infection rates, as Kevin was fearful of in the past slide. And there's decreased flexion strength. A lot of different things going on here. What are your thoughts, Kevin?
Yeah, good summary. I think it's kind of just weighing the advantages and disadvantages of each one for the person in front of you and for their long-term goals and the particular surgeon's preference. So I think it's important to keep all of those in mind and help educate the patient on those things. Like you said, I think the patellar fracture is rare. I haven't seen that. I've heard of it, but I've never seen it. But yeah, I mean, there are pros and cons to each one, and just important to keep in mind throughout the rehab process is how can we mitigate those disadvantages as best as possible.
Well said, Kevin. All right, and just to round things off, we'll talk about the allograft. So the optimal patient for allograft is going to be greater than 40 years old. That's definitely what we see clinically. Generally speaking, they have a low activity level and or physical demand. We tend not to see that always. I will say that the cadaver grafts we see are usually folks over the age of 40 that still want to return to higher level athletics like skiing. Skiing tends to be the big one. And they may be appropriate for multi-ligament knee injuries. Some advantages of the allograft: there's no donor site morbidity. What I will say is, from a physical therapy standpoint, like you said, Kevin, these guys are great to work with. They tend to progress really, really well, minimal pain. It's good stuff. The surgery itself has a faster operation time, which is good. There's a more predictable graft size, which is really nice because you're taking the cadaver, you know what you're dealing with, right? As opposed to going in and trying to harvest someone's own, let's say, hamstring tendon and finding like, okay, this is not the right size and having to make modifications, so on and so forth. Some disadvantages: they have a higher graft rupture rate compared to quad tendon and bone, patellar tendon, bone, especially in young and active patients. They have slower rehabilitation speed due to delayed graft maturation and incorporation. I will say that's misleading because they tend to feel like they're doing better, right? They may get to 8-10 weeks and they're like, oh, I'm feeling phenomenal, right? It's like, all right, well, we have to be careful because that graft is actually not doing phenomenal right now. It is ligamentizing. I don't even know if that's a word, but I've said it like 10 times in the past hour and a half. And we have to be cautious because as these folks are starting to progress and they feel really good, the ligament's not quite at 100% here. So we have to go a little slower with them. The last piece, there are increased costs to using cadaver grafts. So that's something that we potentially have to keep in mind there. All right, moving on. So if you've worked with enough patients that have had ACL reconstruction, you may have seen an LET procedure. That's a lateral extra-articular tenodesis. Oftentimes, it's done in conjunction with an ACL reconstruction. And if you are watching the video portion of this, you can actually see an image of the procedure. What they're doing is they're detaching a part of the IT band proximally. They're transferring that underneath of the ACL, and then they're fixing that to the femur. And like I said, it's performed in conjunction with the ACL reconstruction. I guess apparently, historically, back in the day, sometimes they didn't reconstruct the ACL. They would do just this procedure to try to restore stability of the knee. Now they do it in conjunction with the ACL reconstruction, and it does tend to improve rotational stability. It does also tend to improve return to sport rates with some studies. So Green et al. In 2023 showing a 100% return to sport rate. It was a smaller study size too, but that's much better, obviously, than some of the prior rates we've seen. And it can be used with the quad 10, or at least in that study, excuse me, the 100% return to sport rate was a quad tendon graft with the LET, right? And lastly, they also have decreased re-tear rates. So 11% in the non-LET group versus 4% in a hamstring autograft plus LET group. I know you have a patient right now that has an LET. Any thoughts on this procedure before we move on, Kevin?
Yeah, I think we're seeing it more often in at least the Boston area with patients who are deemed to be a higher risk of re-tearing. So perhaps that adolescent female specifically they're usually just doing it to prevent a subsequent tear. And like you said, with that study, we are seeing a reduced risk of re-tearing, which is awesome. The other time that we're really seeing it is in folks who have torn already and they're having a second reconstruction. They tend to do that again with the idea that you're reducing risk of re-tearing. So it seems like a good choice, and I think more surgeons are looking at that as a preventative measure. And it doesn't seem to really change the rehab process. It doesn't seem to increase pain a lot in these folks. So be on the lookout for that, because we're seeing that more and more, and it is promising, which is great.
Yeah, and I know that Lenny kind of said this, but when the surgeons are doing the ACL reconstruction, after they reconstruct the joint, they may actually do a pivot shift, and if they're noticing there's still not the same rotary stability that they want, they may do the LET then as well, right? And then we'll talk about some indications now. All right, and Kevin already alluded to this, but what patients are going to be appropriate for adding this LET to ACL reconstruction? And generally speaking, these are going to be folks that are high risk to have a re-tear, right? So that would be female population, soccer athletes, elite athletes, so basically folks that are going to perform at a national or international level. If they have inherent ligamentous laxity, they have an increased posterior tibial slope, they have a high-grade pivot shift. So this might be also in surgery if they're noticing that they still have, well, prior to the surgery, the high-grade pivot shift, or after the reconstruction, they're still not happy with the pivot shift, they may decide to do that LET. If a patient had a prior revision, or excuse me, if this is a revision ACL surgery, if they had a prior tear which is repaired, if you're a patient that had a associated meniscal root tear or subtotal meniscectomies, they may consider the LET. Or if they have a chronic ACL tear, when they go in there, they may do the LET as well. All right, the good old regular ACL repair. So this is interesting, but you can actually just repair the ACL. You don't actually have to reconstruct it. And I found a meta-analysis in 2019 from Dr. Wachuku, who's at HSS, and he's actually referred a few patients to us. So I just thought that was kind of interesting. And they did a meta-analysis of studies on ACL repair just to see the outcomes. Essentially, ACL repair used to be more popular back in the day. It's kind of had a little resurgence in popularity. And I think these authors were basically trying to figure out, is this actually a good idea? Should we be doing more of these or not, right? Just because repair strategies have improved over the course of time. So ACL repair is exactly what it sounds like. They repair the torn ACL. They don't reconstruct it. And essentially, the proximal end of the ligament is fixed back to its femoral insertion with anchor sutures. and that's going to be the best strategy for proximal tears, although there are multiple repair strategies. And this really depends on where that tear is. Is the tear more proximal? Is it kind of mid-substance, right? Which may be relevant in the future when we talk about the Baer procedure. Now, why would you consider an ACL repair over reconstruction? And you already noted this, but there's potentially less damage to the knee joint, so via bone portals as well as the graft site. So it doesn't cause as much damage to the knee. And this may potentially create less longer-term osteoarthritis. So repair might be more beneficial from that standpoint, although that's yet to be seen. We need to have more research to see if that actually occurs. And generally, the outcome from this study with Wachuku was that the ACL reconstruction generally outperforms the repair, even in these future studies with better surgical techniques, so on and so forth. And this goes for functional outcomes, as well as patient satisfaction and re-tear rates, with some authors even going as far as saying the repair should be contraindicated in younger athletic patients. And then Hugeslag et al. In 2022, and this was the most up-to-date article I could find, actually found similar outcome measures in the repair versus the ACL reconstruction, but they also said have caution when prescribing to younger athletic patients, just because of the repair rates may be higher in the repair versus the reconstruction. Have you seen any repairs at all, Kevin?
I have not. No, outside of the Baer, I haven't seen any primary repairs, so I don't have a whole lot of experience with that.
I want to say there are some surgeons out of HSS in New York City that will still do the repair. And Dr. Ramappa, who we get a lot of patients from, he spoke recently at the Sports Academy meeting for the APTA. He was saying that some patients are appropriate for the same reasons we just talked about. It is kind of interesting just because the procedure by itself is not as invasive, and for the right patient, older, maybe not getting back to very much, might be the best long-term outcome, right? So not really sure at this point, but I just thought that was interesting. All right. The new kid on the block, the local kid on the block in the Boston area, the Bridge Enhanced ACL Repair, otherwise known as the Baer. Very interesting surgery. So essentially, you have tunnels drilled through the tibia and the femur, similar to the ACL reconstruction, although they end up doing a suture repair, and this has to be with a mid-substance tear. So if you have a tear of the ACL that occurs more proximally, more towards the femur, they probably can't do this form of repair. It has to be a tear kind of the mid-substance of the ACL, right? Otherwise, the surgery is not going to work. And what they do is they suture the repair together, and then they place a bioactive scaffold to the repair site, and they add 10 milliliters of whole blood. The blood gets absorbed into the bioactive scaffold. The idea is that helps with healing. And the scaffold itself contains extracellular matrix proteins, including collagen. They're obtained from bovine tissue, so from moo cows. And that allows the ACL to heal over the course of time, as opposed to trying to reconstruct it, right? So they're basically putting the scaffold over top of the sutured ACL, which hopefully allows it to heal better than doing nothing, right? And one little stat from one of these studies here showed that pigs treated with the Baer procedure had less osteoarthritis over the course of time compared to the ACL reconstruction. So to your earlier point, Kevin, so these repair strategies like the Baer may lend to less longer-term osteoarthritis. At this point, we don't have those longer-term studies, which we'll go over the studies we do have in a moment, but we don't really know if the Baer is going to have less osteoarthritis over the course of time. That's one of the thoughts. Like if we're doing less damage with the surgery, maybe that ends up having a better longer-term outcome, right? Do you have any Baer patients right now, Kevin?
I do. Unfortunately, he retore his ACL. I know that's anecdotal. It's just one case, but he was pretty far out. I believe he was about 7 or 8 months out, and he was doing some single leg hopping at the gym and kind of knee buckled, really strong. I mean, he had incredible strength. I think what we talked about, some of the advantages of a repair in general, is that you don't have the other issues that you see when you harvest a tissue. So he felt really good. And I do think that the Baer protocol is slow and conservative for a reason. I think part of it is that it's still relatively new, so they don't want to be too aggressive early on. And I just wonder if this particular case, he was pushing the limits a little bit too early. But, we'll learn more as we go. So he's actually getting it repaired with another Baer procedure. And he's about 3 weeks out now. And we'll talk about the rehab, I guess, but the early post-op is a lot slower. There's no passive range of motion allowed in this particular case for, I believe, the first 12 weeks, no passive motion from the physical therapist. So part of it,
flexion?
Into flexion. Yeah. Extension's fine. Into flexion. He can actively move into flexion, and he's encouraged to do that, but there is no passive motion from the therapist. And I don't know if that's just this particular motion surgeon's protocol or the Baer in general is opting for that, but it is slower from that standpoint. But again, he feels good, and I think it's because there's no tissue harvested from other places. So, part of it is we have to keep an open mind, and we can't be too upset about the fact that there's no long-term data on it yet. But it's promising that if it has a lot of potential advantages. I think we just have to see what these disadvantages are over the course of time, but it is attractive on paper.
Yeah. It's kind of like the cadaver graft.
Mm-hmm.
No donor site morbidity. Patient feels good, progresses fast, right? Just probably need more research. We're going to go over the research we have so far. So what are the outcomes of the Baer procedure versus ACL reconstruction? There's one study right now. There's a meta-analysis of just 2 studies, which was called Bridge Enhanced ACL Repair versus ACL Reconstruction for ACL tears, systematic review and meta-analysis of comparative studies. This is in 2023, so relatively recent. The problem, only 2 studies at this point, right? And I went in, I looked at those individual studies. It wasn't that hard to do it, just 2 of them. And essentially, the first study, let's say the earlier study, I believe, was all autografts of the hamstring, right? Versus the Baer procedure. It's 20 participants, 10 Baers, 10 ACL reconstruction with the hamstring. I know Lenny's criticism of this study was that they're all hamstrings because he's such a bone patellar bone guy, right? But there's a more recent study that was looking at autografts of both hamstring and bone patellar bone. I tried to look and see how many hamstrings versus bone patellar tendon bone. They didn't note on that in the study, but it was 100 participants. There was 65 Baers and 35 ACL reconstructions, which were mixed between patellar and hamstring in that study, right? And they looked at a variety of outcomes. So essentially the IKDC score and the KOOS, and the Baer had better short-term outcomes, similar to what you were kind of finding potentially, and had a similar long-term outcome. That makes sense. Maybe it's that donor site morbidity with the reconstruction. And after a while, essentially the reconstruction kind of catches up. So if you look at failure rates, there's no difference between groups, which I think is nice, right? Like you said, N of 1 anecdote, you saw a tear. I mean, if you work with ACLs for long enough, you're going to see tears. It's going to happen, right? Sure, the Baer is no difference from what we're seeing. But that was interesting to me. The re-tear rates were about the same. And then anterior posterior laxity. So looking at that KT1000 testing, no difference in laxity at all time points, which I think is, good stuff. In terms of strength, looking at strength of the hamstring, the quadriceps, and hip abduction, the Baer outperformed the ACL reconstruction for hamstring strength only. And this is because probably majority of the folks in this meta-analysis were hamstring autografts. So that makes sense. We know they're going to be a little bit weaker. When you look at hop tests, the Baer produced a better 6-meter distance hop, which, to be honest, I don't even know what that test is. But imagine you're set up 6 meters and have patients hop, and as many hops as it takes to get 6 meters. I'm not even sure what that is. But they used other hop tests, and the results were the same between groups. In terms of return to sport clearance, and I didn't really like that they used return to sport clearance, but essentially they were trying to figure out at what time point were folks cleared to return to sport. It wasn't their return to sport rate, and it wasn't return to sport at what level, like we're used to seeing. So that was, I'm not sure why that authors wanted to look at that. I mean, in the study, they said that that's a gap in our literature, which they wanted to basically figure out what these were. But I would have been much more, wanting to see the actual return to sport rates and at what level play, but they didn't report that at all. So here's what they found. By the 1 year mark, an estimated 88% of the bear group and 76% of the ACL reconstruction group had been cleared to return to sport. And it was similar at the 2 year mark. But this was most likely explained by hamstring weakness. Because the ACL reconstruction group was weaker in the hamstring, they weren't given clearance to return to sport as much. And that was the main deficit, right? So at the end of the day, I don't know how much this tells me, besides the fact that, the hamstring group is weaker, which we already kind of knew, and the bear seems to do better a little bit faster. And then maybe the hamstring kind of catches up, which we already know that happens over the course of time. We definitely need to know these return to sport rates and the return to sport rate at the same level. That's going to be very, very important. I think that's, once we get some of that data and then maybe some of the longer term osteoarthritis, then I might start to say like, okay, this bear really does seem like it's going to be a good option. Plus, if you look at the study sample size, it's pretty dang small, right? I mean, we've got studies, ACL reconstruction, of like 50,000 ACL reconstructed knees to look at these re-tear rates. Like this is a total of 120 total patients, right, across all groups. So that would be my major complaint, and reservation. I think the bear seems like a really cool procedure, but, we still got to pump the brakes and make sure that, we don't jump the gun here with this procedure. Any thoughts there, Kevin?
Yeah, I think that you want to help your patient understand what's known about the current procedure that they might do. So I feel like if I had a younger athlete who's really trying to return to a higher level sport, we have long-term data and we can feel confident that they can get back with something like a patellar tendon bone graft or a hamstring or quad tendon graft. For someone in that position, I don't know if I would yet recommend they do the bear, just because I would tell them that, it could totally work. We just don't know yet. We need more long-term data, and it's up to the patient and their comfort level of being kind of an early experimenter. But I do feel like for me, if I tore my ACL, I think I would consider the bear because I run. I don't do pivoting cutting sports. And not that it's not going to be good for that. We just don't know. But I would be okay accepting risk of doing something that's slightly unknown just because of what I like to do in my activity level. It's not cutting, pivoting sports at this point in my life. It's running in a straight line, working, being in the gym. And I think it would be cool to do the bear. And it's attractive to me that they're not drilling into your tissue. And I feel like common sense would tell me that over time we would see less rates of arthritis. And I know you had mentioned some animal studies show that. And I know that's how they market the bear. Like if you look on the website of surgeons that do the bear procedure, one of the first things they tell their patients for education is that you're likely having less risk of arthritis. So for me, in my point in life, I would consider doing the bear, or I would consider doing non-op rehab and see how it goes. But that's just my own opinion on myself. I think it would be fun to figure that out. But you want to let your patient know that if you want to get back to higher level activity, we have more data on these reconstruction options. So maybe that's better for you if you don't want to take the risk of being kind of a guinea pig.
Yeah, I kind of agree with you. It's almost like you want to, we're physical therapists, right? We do this for a living. We're very interested in it. It's almost like I would want to try it just for the experience, you know? Totally. I don't know that I would counsel my patients to do it, but just because it's an interesting idea and I like the idea of it, and I'd like the experience. It's almost like visiting the Amazon or something. Like I love, seeing capybaras. I have no idea there's capybaras in the Amazon, but like, just because you want that experience, you're like so into it. Just the whole rehab, the nature of it just seems interesting. Right.
Yeah.
But yeah, I do think that at the end of the day, just because it's interesting doesn't mean it's always the best, but it is kind of cool. And I like the idea as well, just like you had said. All right. So now you have a lot of information about the different types of surgeries for your patients after they have an ACL tear. Now you should probably know a little bit about whether or not you should do conservative care or physical therapy, or you should have surgery in your patients after ACL tear. And I've got a video for you. It lives directly over top of Kevin's head. go ahead and click on that. We'll go over surgery versus physical therapy for ACL tears. See you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain-Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.